Welcome to this training on using the Interactive Clinical Practice Guideline tool for screening and identification of autism spectrum disorder, or ASD, in the primary care setting. The overall purpose of the training is to describe the clinical practice guideline algorithm and demonstrate the use of the interactive tool. The demonstration will be augmented by summaries of the evidence that support the guideline and examples of suggested screening tools. The screening tool and this training were developed specifically for the Humana Military TRICARE network providers. After completion of this training, you may be eligible for continuing education or continuing medical education credits. Details regarding education credits are provided at the end of the session. The goal of this guideline is to ensure that further assessment and treatment takes place for all children when needed. Appropriate use of an autism screening tool in your primary care office will help you not only identify those who need this attention, but also help you efficiently and more accurately identify children who do not need further evaluation, thus avoiding unnecessary referrals. The clinical practice guideline presented here and the supporting resources are intended to enable screening of patients in the primary care setting and appropriately identify patients with a higher likelihood for the diagnosis of ASD and who require further evaluation, to inform family and providers regarding the appropriate need for referral for specialty care, and to aid in avoiding excessive or unnecessary referrals. Autism is a neurodevelopmental disorder that can cause significant impairment in social, emotional, behavioral, and communication skills. Individuals with autism characteristically exhibit restricted, repetitive, and stereotypical patterns of behavior. Autism is described as a spectrum due to the wide range of disability and severity of symptoms associated with it. There can be considerable variation in cognitive, intellectual, emotional, psychiatric, and neurological comorbidities. Symptoms are generally noticed during the child's first 3 years. Although the severity of the symptoms can vary greatly, all persons with autism exhibit some level of impairment in the area of social interactions or relationships, verbal and nonverbal communications, and limited interest in activities or play. This brief presentation around using the clinical practice guideline will not provide further detail on the clinical manifestations of ASD. However, a list of resources is provided at the end of this presentation. The prevalence of autism has increased in recent years and is reportedly estimated to affect 1 in 59 children. It is unknown if this reflects a true increase in prevalence or if improved case identification coupled with increased awareness has caused the rise. It is 4 times more common in boys than girls. Evidence also suggests that siblings of affected children are at elevated risk compared with the general population. Other risk factors include extreme premature birth, for example, birth at less than 26 weeks gestation, advanced maternal or paternal age, close spacing of pregnancies, family members with learning or language disabilities, and genetics. At the end of this video, you should be able to explain the benefits of early identification and treatment of ASD, describe the application of the clinical practice guideline algorithm in a primary care setting to determine who should be screened for the risk of ASD, describe the application of the clinical practice guideline algorithm to identify patients who should be referred for further evaluation or treatment while avoiding excessive or inappropriate referrals, and describe types of services, resources, and referrals for patients and families who will require evaluation for ASD. Expert opinion generally supports and promotes early identification and intervention. Early identification can help reduce or ease family and parental stress by putting an end to the diagnostic odyssey. easing the family's burden with community-based services, support groups, and respite care, and initiating an investigation into the risk factors and causes of autism or other developmental disorders, and thereby helping to inform future reproductive decisions. More importantly, early identification can lead to early childhood educational services, speech therapy, physical and occupational therapy, and medical care planning. These therapeutic activities may prevent secondary effects of atypical development and the emergence of a more fully developed autism profile. By intervening during a time of rapid brain development, the hope is to maximize outcomes such as IQ, language, symptom severity, and core deficits of ASD such as social attention. Many of these early interventions are publicly available following a positive screening, even before a diagnosis is confirmed. Contact your state, county, or local health agencies about access to public sector early intervention educational services. Two types of developmental evaluations may occur in the primary care setting: surveillance and screening. Surveillance is the process of recognizing children who may be at risk of developmental delays. Developmental surveillance is a flexible, longitudinal, continuous, and cumulative process whereby knowledgeable healthcare professionals identify children who may have developmental problems. Surveillance does not involve the use of standardized, validated tools. Areas of interest usually include fine motor control, gross motor control, social emotional behavior, self-help, and expressive and receptive language skills. Developmental patterns are assessed for delays, deviance, and most importantly, regression. Brief clinical observations and developmental surveillance may not provide enough information about atypical behaviors and may fall short in reliably detecting autism risk. Clinical impression may miss delays in the domain of social and communication skills. Studies have shown that children who screen positive for autism using an ASD-specific screening instrument had not previously raised parental concerns when screened with a standardized general developmental questionnaire. Screening for autism is a specific, systematic interview designed to more accurately identify children who are at risk. The process usually involves a standardized, validated instrument primarily filled out by the parent. Questions address developmental signs associated with autism. The use of a validated tool ensures that the screening instrument has been tested for accuracy and that it is a reliable, valid, and sensitive measure of autism risk. We have recommended going directly to a level 1 risk screening tool, as described in a few moments, rather than depending on surveillance. Children should be screened specifically for autism. In response to parental or clinician concerns related to delays in achieving language and communication milestones and/or regression in social skills. It is important to note that early findings may not be the typical ASD findings, so ASD should be considered when problems are identified or noticed. Children should also be screened if found to be exhibiting stereotypical behaviors known to be associated with autism, or if the child has a sibling with a confirmed diagnosis of autism. In addition, all children should be screened during the 18 and 24-month well-child visits, regardless of symptoms or concerns. While delays in social communication may be subtly present near 12 months of age, they may not be specific to autism at that young age. Early screening for autism may be associated with higher false positive rates, but may be of value in detecting other developmental delays. This next section of the training will demonstrate some of the features of the interactive clinical practice guideline algorithm and familiarize you with using it. The image on this slide shows the complete clinical practice guideline algorithm developed specifically for Humana Military TRICARE network providers to assist them with the screening and identification of ASD in the primary care setting. The algorithm tool is interactive, meaning that clicking on some of the shapes, for example, the number 2 diamond, will provide additional information about the decision point or action under consideration. Clicking on the small flowchart icon will return you to the main algorithm slide. The green diamond shapes are questions or decision points. These lead to either another question or decision point or to a gray rectangle, which represents a specific action. The algorithm begins with questions about the child's age and purpose for primary care visit. Based on yes or no answers to these questions, the algorithm leads to additional questions or specific actions. If the path leads to a recommendation to administer a validated ASD screening tool, such as those in boxes 4A and 8A, for example, a list of available tools is provided in the supporting documentation that accompanies the algorithm. A few of the available ASD screening tools for children younger than 3 years of age are listed on this slide. Please consult the supporting documents for information about these and other tools. Screening instruments designed for older children and youth, for example, the Autism Spectrum Screening Questionnaire, or ASSQ, were not included in the development of this clinical practice guideline because the focus here is directed at early identification and intervention. Barriers to universal screening have included limited time and resources. The selected screening instrument should be comprehensive in assessing the core domains affected by ASD and require a reasonable amount of time for administration. Most Level 1 tests can be completed by parents or caregivers in the form of a questionnaire and take about 10 to 20 minutes. Follow-up interviews or Level 2 testing, if indicated because of a positive screen on Level 1, will require additional time by a dedicated, trained staff member. Each screening instrument was designed and validated for a specific age range. Tools should be selected to meet the practice needs and targeted population. Most screening tools are available in several languages. This clinical practice guideline recommends using the modified checklists for autism in toddlers revised with follow-up, also known as MCHAT-RF. Briefly, the MCHAT-RF is designed for children 16 to 30 months of age. It is a two-stage process, the first of which is a set of 20 yes or no questions intended to be answered by the child's parents or caregivers. The MCHAT-RF is available free to providers. Scoring of the MCHAT-RF is based on total scores from parent report and/or interview. 1 point is assigned for each answer that indicates ASD risk. For the first phase, there are 3 possible risk levels based on ranges of scores. Range 0 to 2 is low risk, range 3 to 7 is medium risk, and range 8 to 20 is high risk. This section of the clinical practice guideline algorithm shows the pathways for the low, medium, and high risk categories. Actions for low risk scores from 0 to 2 and high risk scores from 8 to 20 on the MCHAT-R are described in box 9B. If a child receives a low risk score and is younger than 24 months, screen again after the second birthday. No further action is required unless surveillance indicates risk for ASD. If a child receives a high-risk score from 8 to 20, the child may be referred for diagnostic evaluation and eligibility for early intervention. The MCHAT-R follow-up interview may be bypassed in this circumstance. Children with scores in the medium risk category ranging from 3 to 7 need to have the MCHAT-R follow-up structured interview administered to parents or caregivers. This interview needs to be done by trained staff and can be performed on the same day or during a separate visit scheduled in the future. The follow-up interview uses the same questions as the Phase 1 MCHAT-R. However, the structured interview guides the trained interviewer by providing examples and prompts to elicit more detailed responses. Responses are scored as pass or fail. If the follow-up interview score is 2 or higher, the child should be referred for diagnostic evaluation and evaluation for eligibility for early intervention. If the final score is 0 to 1, no further action is required unless surveillance indicates risk for ASD. The child should be rescreened at future well-child visits. If results obtained from the screening tools are positive, meaning that they indicate the possible presence of signs and symptoms of ASD, referral for further evaluation and diagnosis may be appropriate. Documentation supporting the algorithm provides details about subspecialist referrals. Referrals for further evaluation and treatment are indicated for children who screen positive. For example, if there was a high-risk score in the Phase 1 MCHAT-R, or there were 2 or more positive questions on the Phase 2 follow-up interview. Positive screening results should be validated with clinical judgment and a thorough review of past medical history, family history, and a physical exam. The American Academy of Pediatrics recommends that children who screen positive be referred for ASD diagnostic evaluation and for early intervention services, which may include nonspecific ASD services provided by a public entity, such as speech therapy or early childhood education programs. The comprehensive diagnostic evaluation involves a multidisciplinary team led by a developmental pediatrician, child psychologist, a pediatric neurologist, or child psychiatrist trained in autism detection. The team may include a speech and language pathologist, a physical therapist, and an occupational therapist. In addition to subspecialty referral, the child should be referred to an audiologist for a thorough hearing evaluation and tested for lead poisoning and possible metabolic testing. If there is concern for seizure activity, an electroencephalogram is indicated. A genetics referral may be indicated, especially in the presence of dysmorphic features. Additional testing should be left to the discretion of the clinical specialist who will complete the diagnostic evaluation. Suggesting resources for children and families are an essential part of screening and referral practices. Resources can help families find services and support in their communities and educate them on the topic of autism. The algorithm and supporting documents list some resources for helping families who have children with suspected autism. Additional resources for healthcare providers are also described in the materials. Some resources for parents, patients, and families are shown on this slide. The resources were developed by agencies and organizations such as the Centers for Disease Control and Prevention and the American Academy of Pediatrics, among others. Additionally, numerous entities, such as those listed here, have issued professional guidelines or recommendations regarding screening. More information and internet links to these guidelines are available in the supporting documentation. This example follows one of the possible pathways through the clinical practice guideline algorithm for screening a child for ASD. Remember, when you are using the interactive algorithm, you can click on some of the diamonds or rectangles to get additional information about a topic. Let's begin the example. First, a child presents for a primary care visit. At this time, the provider determines whether the child is younger than 18 months. The child is older than 18 months, and the provider asks if the child is present for a routine well-child visit. The answer is no in this case, and the child is present for another reason. At this juncture, the provider ascertains whether or not there are findings suggesting a neurodevelopmental disorder and/or autism. In this example, the answer is yes. Therefore, the clinic staff determine whether a validated ASD screening tool is available for the parent or caregiver to fill out while still in the office. In this case, a screening tool was available and provided to the parent or caregiver. Upon scoring the responses to the questionnaire, clinic staff ask if 3 or more questions indicate ASD risk. For this example, the answer is yes. Therefore, a structured interview is administered to the parent or caregiver on the same day or during a separate visit. Upon scoring the results of the follow-up interview, if 2 or more responses indicate ASD risk, the child will be referred for further evaluation and treatment. Use this link to the Humana Military website and the instructions shown on this slide to familiarize yourself further with the clinical practice guideline and related documents. That concludes this educational activity. To receive continuing education or continuing medical education credits, please complete the online evaluation and post-test and pass the post-test with a grade of 75% or higher. If you have any problems receiving certification, please contact the Postgraduate Institute for Medicine. I would like to thank you for your time and attention.